Hello? Okay. All right, so should we get started? We're at the last session. Thanks for those that have stayed. You're the real fans. Dr. Stephen Lin and I are going to jointly do the session on difficult cases in thoracic cancers. So I'll present the first two cases, and Dr. Lin will present the last two cases. Again, my disclosures, Dr. Lin's disclosures. So the first case is an oligometastatic case, and you've heard from Dr. Tsai that this entity isn't new. It was first proposed by Waxelbaum and colleague, hypothesizing there's a subset of patients that might benefit from local therapy because their oligometastatic disease, if when they're treated, could lead to survival or local control benefit. And we're learning more about metastases. We won't get into a lot of the detail, but other than say it's very heterogeneous. However, we know now that tumors can metastasize in different ways, from primary to the lymph nodes, and lymph nodes to the back to the primary, et cetera. And this kind of pattern of metastases helps us understand how local treatments can alter the natural history of metastatic cancers. So what are the benefits of local therapy? As we know that as systemic treatments for lung cancers improve with immunotherapy and targeted therapy, it becomes more and more important that local therapy and local control to treat the resistant tumors it might lead to better outcome. And some of these other benefits include that local therapy can prevent complications, either surgery, local therapy, or radiation can do this in a very safe manner with low toxicity. And again, there's emerging data that immunomodulation could improve when you combine radiation and ablative doses to immunotherapy. So here's the first case, 63-year-old man, never smoker, good performance status, presenting with left neck mass and a large, bulky left upper lobe tumor that's 5.3 centimeter, involving the bilateral mediastinum, portohepatis, negative MRI of the brain. Pathology shows adenocarcinoma, EGFR mutated, and PD-L1 was high. So this is the first audience response question. What systemic therapy would you offer this patient? Can we go to the results? Interesting. So even though the PD-L1's high, because this patient has EGFR mutation, the standard would be to offer the patient osimertinib. So this patient was treated with osimertinib for 3 months with some mild skin rash. PET scan shows excellent response with a residual 3 centimeter tumor that's FDG negative in the left upper lobe. What would you do next? So continue osimertinib, consolidate with the primary with surgery or with radiation, consolidate everything, or just the primary in the chest. Interesting. So some people would say just continue osimertinib. Some would consult with surgery, and some would say consult with everything. So there's no right or wrong answer per se, but we end up treating the primary with radiation with the idea that typically failures after targeted therapy happens in the original sites of disease and at the original bulky site. So this patient was treated with hypofractionation, 70 gray in 10 fractions. After that, the patient continued on osimertinib for another 18 months with no evidence of disease. At 2 years, the patient then on a PET scan showed a retroperitoneal FDG avid node. What would you do next? Continue osimertinib and repeat scans, biopsy, switch systemic therapy, or consolidate the retroperitoneal with radiation? Okay, so majority of people would do a biopsy versus switching therapy, and I think that's the right answer. Many times we want to repeat the biopsy to understand the mechanisms of resistance and potentially other targetable mutations. Unfortunately, this patient just continued on osimertinib, but the retroperitoneal node continues to get larger and no other lesions were seen. The biopsy was attempted, but was complicated by bleeding, so no tissue was obtained. And this slide just to show that these lymph nodes are actually from the original sites of disease. So they're not really new sites, but recurrence of the original responsive sites to osimertinib. So ultimately, the patient was treated with local therapy to the retroperitoneal nodes. 40 gray in 10 fractions was given to the gross disease, with 30 gray in 10 fractions given to initial sites of retroperitoneal nodes. So we're just going to quickly go over some of the existing randomized trial for oligometastatic lung cancer. Probably seen many of this today and in the past. So one of the early trials was this phase 2 trial from MD Anderson and another institution, hypothesizing that oligometastatic non-small cell lung cancer after induction systemic therapy could benefit from local therapy. Primary endpoint was median progression-free survival, criteria including patients that had less than 3 equal metastases after induction systemic therapy, allowing for targeted therapy and chemotherapy. This trial, again, patients were given systemic therapy and then randomized to either consolidated radiotherapy if they had limited sites of disease remaining versus continued systemic therapy. And their primary endpoint was progression-free survival, which showed that LCT increased the PFS, but also interestingly, it showed that there was a delay in the development of new lesion, suggesting that LCT could alter the natural course of disease by limiting the potential for subsequent metastases. This was an update of the trial results, again showing that not only PFS was improved, but also overall survival was higher in patients that had LCT, which is impressive in that the patients that had recurred after systemic therapy could cross over to LCT, and that didn't actually wash out the benefit of local consolidated therapy. A very similar trial was done at UT Southwestern with non-small cell lung cancer treated with local therapy, SABR, after chemotherapy versus standard of care. Again, showing PFS benefit of 9 versus 4 months. And you know, LCT, the dose is variable and it's at the treating physician's discretion, and it could vary from SBRT to 15 fractions mostly. Again, SABR Comet has been talked about a number of times, but it randomized patients 2-to-1 with various histology to SABR versus no SABR for patients with upfront metachronous oligometastatic disease. The primary endpoint was overall survival with a 0.2 value, p-value. This did show overall survival benefit across all patients and also PFS benefit. However, there was some concern about the heterogeneity of patients with more patients with prostate and breast cancer, potentially skewing the results toward a benefit in more indolent disease. But overall, one of the take-home messages that, at least in this study, there was toxicity related to SABR in terms of grade 2 and above, and also almost 5% grade 5 toxicity in SBRT arm, cautioned us that SABR isn't completely risk-free if done, when done. So that's the first case. I'm going to move on to the second case, which is a salvage reirradiation case. So this is a 65-year-old woman with initial stage 3A non-small cell lung cancer, T2N2, with good performance status and received chemoradiation and durvalumab more than a year ago. This was the original plan showing the treatment of the primary and the mediastinal disease. After more than a year, the patient has a PET scan that showed local regional in-field and out-of-field recurrence in the right mediastinum and also in the original sites of disease. Oops. So the next question is, what would you do next? Offer second-line chemotherapy, offer reirradiation with photons, offer reirradiation with proton therapy, or reirradiate in general and give durvalumab? Okay, so majority of people would re-irradiate and restart durvalumab. That's interesting. Makes a lot of sense. So in general, this is some of the data which is limited for re-irradiation. We know up to 25–30% of patients could have isolated local regional recurrence after definitive therapy. This is from the original RTOG 0617 studies showing a high local failure rate. Even in Pacific, despite a higher 5-year survival or 4-year survival, there was also significant patients that have just local regional disease only. The data for salvage re-irradiation is relatively limited. We know that systemic therapy alone has poor prognosis, essentially palliation with a relatively short progression-free survival and median overall survival. Small series have shown the feasibility of re-irradiation in highly selected patients that are suitable for this approach. Here are some of the data for salvage re-irradiation. Most of the cases, again, are relatively low quality data and retrospective, showing that the median local regional control is 2 years, 25–75%, 2-year survival, 33–55%, and 2-year PFS, 15–40%. However, so there's significant toxicity re-irradiation, and it's important to highlight these toxicity of previously treated organs at risk. Overall, 30–40% of the patients have grade 3 and higher toxicity, namely severe pulmonary toxicity, fatal bleeding from a vessel blowout, or grade 3 and above esophagitis or fistula in the orders of about 10–25%. Current methods for manually calculating translational dose is not optimal, but it's the best way we could estimate the risk of re-irradiation. So these are some of the guidelines that are based on the literature that we followed at Anderson and other places. So for example, for proximal bronchial tree, data suggests to avoid grade 4 or 5 toxicity to keep the cumulative doses to 100 and 110 gray. Similar for gray vessels, 100 to 120 gray, and esophagus to less than 90–100 gray. We also want to keep track of the total lung dose, mean dose, and the V20 to be able to evaluate their risk of pulmonary toxicity. And of course, there's higher toxicity with re-irradiation for centrally located tumors. So in addition, if the tumor is close to the brachial plexus or spinal cord, we want to keep the goal Dmax of cumulative dose of 85–90 gray for the brachial plexus to minimize 1-year plexopathy. And for spinal cord myelopathy, use a goal BED2 of less than or equal to 135 gray to have a 0–3% risk of myelopathy. And it's important to look at the picture holistically for the patient. It's important to make sure that you properly work up the patient with a restaging, imaging, biopsy, MRI to make sure that the patient truly has local regional disease only. As far as timing, patients that have longer disease-free interval are more ideal patients for re-irradiation. And if it's possible, you can consider induction chemotherapy followed by re-irradiation. And when reasonable concurrent therapy can be delivered with treatment, but it of course offers higher risk of toxicity such as esophagitis. So in this case, the patient had a local regional and also out of the field recurrence. The original plan delivered a maximal esophageal dose of almost 70 gray, mean lung dose of 18, V20 32%. This patient was ultimately treated with proton therapy, 60 gray re-irradiation plus chemotherapy, and the composite lung doses were approximately 22 gray, esophageal dose was 98 gray, and the lung V20 was 38%. So additional data for patients on the modern regimen of chemoradiation durvalumab shows that at 2 years, 45% of patients have progressed, but majority of those patients have only progressed in the thorax. And of those that have progressed, 2/3 have just 1 to 2 new lesions, and majority of the new lesions are within one organ. So we started the study at MD Anderson looking at the use of local consolidation therapy and continued durvalumab in these patients, looking at benefit in terms of PFS. And just quickly going through this study, it's ongoing, but we separated the cohort by the number of sites of progression And the local therapy could be either surgery or radiation, and radiation to at least 1 lesion up to 5. Patients would continue durvalumab 2 weeks after LCT. Patients with polyprogressive disease would get also concurrent chemo for 4 cycles plus maintenance chemo if appropriate. Here's the study schema showing the 2 cohorts of patients, and after LCT they would continue either durvalumab or durvalumab plus chemotherapy. Patients had to have stage 3 up front, treated with chemo, radiation, durva, and then progress or have residual disease, but they have to not progress within the first 3 months, because rapid progressors generally do poorly, and the endpoint's PFS at 2 years. The regimen for radiation is what we would consider standard for these patients, depending on what's feasible, either SBRT if they're out of the prior treatment field and small, or a non-SBRT regimen if they're limited by the organs at risk based on the prior radiation dose. So with that, I'm going to hand off to Dr. Lin, who's going to talk about cases in small cell lung cancer.
All right, as promised, thank you for holding out till the end. So a few of you, hope there will be some questions actually, so hopefully you guys will be able to respond for some of the upcoming questions. And this is, we're going to start talking a little about small cell. We didn't have a chance to do so early on, so this will be hopefully a little bit of didactic as well. So this is a case. Case number 3 will be a 68-year-old woman who presents to a local physician with a hemoptysis. A CT scan shows a mass in the chest that was concerning for tumor, and then the PET scan shows extensive nodal metastases, left hilar, bilateral mediastinal adenopathy, left supraclavicular adenopathy, as well as a small pleural effusion, no obvious pleural involvement, however. So the biopsy was done on the left supraclavicular mass node, showing by ultrasound guidance, and shows a small cell carcinoma. And the MRI was done and was negative. So based on the information that was given to you, how would you stage this patient? Either limited stage, extensive stage, or there's too little information to be able to stage. Very good. All right. So all you believe, well, we could be able to treat this based on the definition, right? And then, so we're going to have 3 consecutive questions. So this is the second of the series of the questions. So what would you recommend for treatment for this patient? A, chemotherapy with immunotherapy, chemotherapy alone for 6 cycles, chemoradiation with immunotherapy, or chemoradiation alone. All right, a split decision, chemoradiation with immunotherapy or chemoradiation alone. Interesting, okay. All right, so now the third question is that if you decide to do chemoradiation, what is the standard care regimen? And then you have it listed there, carbo, etoposide, 45 gray and 30 over 3 weeks. Same regimen, 70 gray, 35 fraction over 7 weeks. Carbotaxol, 45 gray and 30 fraction over 3 weeks. Or carbotaxol, standard fraction 60 gray of 30 fractions, followed by durvalumab. All right. So as you know, of course, there is actually a right answer for this. Well, no, there's no right answer. There's actually multiple right answers. However, the D is actually not the right answer because that's more for non-small cell lung cancer. So A is actually definitely appropriate, certainly, and that's one of the regimens, and we'll review that going over the actual data. So, of course, we're limited to say small cell. This is the thoracic regimen, which is intergroup 0096, which, of course, randomized patients to 45 gray at 1.5 gray BID. That's the experimental arm versus a control arm, which is 45 gray and 1.8 gray QDay. And of course, PCI was offered in patients who had complete response. As you know, of course, the trial was positive, showing, demonstrating that twice daily radiotherapy over 3 weeks was better than actually doing Q-day radiotherapy. But there's a lot of criticism of this, of course, is that because there's not truly equivalent, right? Because Q-day radiotherapy in 45 gray, although the dose is the same, is really truly not the same BED between the two. There was higher grade 3 esophagitis, 27% versus in the BID versus the Q-day of 11%. There's some differences in definition in subsequent years. However, still there was actually increasing toxicity. But of course, we know that they based in the old days with in that time with the intergroup, they treated extensive elective nodal radiation, particularly actually bilateral superclav, the entire mediastinum, even 5 cm below the carina. Nowadays, of course, we don't do that. We treat PET-directed radiotherapy. So we wouldn't expect the same type of esophagitis now as back then. And this is actually evidence from the more modern trials. This is a CONVERT trial, which, of course, in the modern era, wanting to ask the question whether, instead of the Q-day regimen of 45 gray, how about we dose escalate above that? Are we going to see a benefit? So this is of course, the thoracic regimen of 45 gray BID versus 66 gray Q-day. The CONVERT trial is a 1-to-1 randomization. And this is where you see actually that even with modern technology or conformal radiotherapy, you're actually not seeing the type of toxicity that we saw back in the thoracic era, where they're not treating extensively in the mediastinum. But however, based on of course, the curves, you see actually there's no differences in the outcomes between the two arms. And the conclusion of this trial is that actually the thoracic 45 gray BID is still the standard of care, because the hypothesis for this is that the Q-day was going to be beneficial or better. So the RTOG 0538 is the equivalent. So that was a UK. The CONVERT study was a UK study, and this is actually essentially the equivalent RTOG and the US study. This is a trial that actually is initially a 3-arm study, with the control arm being the thoracic regimen, and 2 additional Q-day regimens, or actually one is a Q-day regimen, 70 grade and 35 fractions, versus a concomitant boost regimen, which is the MD Anderson regimen. Ultimately, that was eliminated based on various reasons. There was an interim analysis showing there was no differences between arm B and arm C, and therefore they had to eliminate one of the arms, so they eliminated the concomitant boost, which is a little bit complicated. So they really just compare the Q-day versus the BID regimen. And of course, we know this is actually it was presented at Astro, and then of course it was published just last year, just earlier this year, sorry. And there's no differences in overall survival or progression-free survival. It took like a decade to finish, and unfortunately, there's really no differences, and also no treatment-related toxicity between the 2 arms. So based on this, actually still demonstrates that the thoracic regimen or the BID regimen is still the standard of care. Now there's actually increasing evidence suggesting that potentially using the BID approach, if you dose escalate using the BID approach, potentially there will be an improvement in outcomes. And so this is a Norwegian study. Although it's a phase 2 randomized trial, and certainly not a definitive phase 3. However, it's interesting information data here. They randomized patients to the thoracic versus escalating above 45 gray to 60 gray, and all patients received the same chemotherapy. So what they found is actually there was an improvement in overall survival in patients who actually received dose-escalated BID regimen compared to the standard. And there's actually some additional data. There is a phase 3 trial conducted, not yet, and it's read out, however, not yet published, which I won't present here. I suggest that actually there could potentially be a benefit as well with the dose escalation above 45 gray. So I think this eventually will change our approach to treating small cell, that we will be going above 45 gray, particularly using simultaneous integrated boost type of approaches, where you don't need to do this sequential boost. You can just do simultaneous integrated boost to improve outcome above what we're doing in thoracic. And finally, having some advances in this field. So this is for this particular patient. Of course, copper etoposide was used as standard regimen, and in 4 cycles. Radiation was, of course, standard thoracic regimen over 3 weeks. Core max is 32 gray. Mean esophagus is acceptable at 31 gray, and mean lung dose also acceptable. And so this is, so patient received, of course, complete radiation in the 4 full cycles of chemotherapy. And patient only had, despite the extensive nodal metastases, patient only had grade 2 esophagitis. There was relief from narcotics. And the repeat follow-up CT scan shows complete clinical response. Of course, the MR brain is negative for metastases. So next is actually, so what would you recommend as the next steps? Is atezolizumab for a year, durvalumab for a year, prophylactic cranial radiation or observation. All right. So majority of you, and actually that is the board correct answer, that the PCI in the patients with limited stage disease is still considered standard, but then actually some of you will actually potentially will vote for observation, which I think in this era, I think it's actually potentially correct as well. Although we don't have the definitive answer, and certainly that's being explored in a trial called the Maverick. However, I think it's something that we actually are discussing with our patient currently. And so this is so there is a trial that's completed called NRG L005, which is a phase 3 randomized trial with randomizing patients to standard chemoradiation, and that could be either the BID or the Q-day regimen, plus or minus atezolizumab. And so this is actually a trial that was completed. We still not yet read out. We are hopeful it might be positive, but however, we cannot say anything about this. This potentially will become practice changing in the future if this is positive, of course. However, incorporating immunotherapy in this setting is still not the standard of care, and you cannot even get it approved. So right now, chemoradiation is still just the current standard. However, the role for PCI, of course, we know based on multiple studies, and this is, of course, the operant meta-analysis with PCI, showing that PCI in patients with limited stage small cell, it improves by 5%. So this is well known. However, actually, but of course, there's a lot of caveats, I just want to say, because if you actually look at those old trials, brain imaging was not required for a lot of these trials, right? So probably some of these patients, and some of the patients even had brain imaging that use CT scans, not very sensitive to detecting small amount of disease in the brain. So it's all likelihood some of these patients actually, when they were randomized, already had brain metastases. Maybe not symptomatic, but already have brain metastases. So PCI, of course, benefited those patients. So what we did actually at MD Anderson, we looked at our own experience and looking at patients in the MRI era, of course, patients who are initially, initial staging with MRI, demonstrating they don't have brain metastases. And then some patients, of course, majority of patients got PCI. Some patients did not get PCI for one reason or another, either patient refused or physician refused for one reason or another. But we actually look at our outcome, and we find that actually, surprisingly, that the cumulative incidence with and without PCI of brain metastases was actually not statistically significant, probably because of the small number of patients. Although you can see these are matched analysis of patients in the PCI group versus non-PCI group, or 84 patients in each group. There was no actually not statistical difference in terms of metastatic disease in the brain. But more importantly, there was actually no difference in overall survival, whether a patient was treated with PCI or no PCI. But that's a retrospective, and certainly this is actually now a international trial called the Maverick, which is actually trying to ask this question in the era of MRI surveillance, whether with proper baseline imaging of the brain, whether PCI is still important. And so this is a trial, of course, randomized patients to that, to PCI versus no PCI, with overall survival being the primary endpoint. Okay, so hopefully we'll be able to finally definitively answer this question whether PCI is necessary for small cell lung cancer. So back to the case, of course, PCI was discussed with the patient, and a consideration was made to enroll to the Maverick trial to do PCI or observation or protocol. She actually wants to do what's best for her. Basically, he's always kind of leave it up to the physician what I think is best for her. But she was concerned about the side effects of PCI, mostly related to neurocognitive disorder, right? So what would you recommend then after having this discussion with the patient? So watchful waiting, 25 gray in 10 fractions PCI, 30 gray in 10 fractions with PCI, or hippocampal avoidance PCI. Oh, interesting. Okay. So some will observe, some will just go ahead and elect to do 25 gray. I think that's very reasonable because it is still standard of care currently, right? And then, but then to offer PCI, but using hippocampal avoidance. And actually, this is a very important consideration. So I'd like to go over some of the evidence, and it's actually a little bit controversial at this point. So this is actually, of course, the CC001 trial, which is actually for whole brain radiation. So this is whole brain radiation, not PCI. These are patients with actual brain metastases. And then this is a trial, of course, they randomized patients to whole brain radiation plus memantine, plus or minus with hippocampal avoidance. As you can see here is that, this is hippocampal avoidance, they actually just try to minimize the dose of the hippocampus with a Dmax no more than 8 gray. You can see here is that there was actually an improvement in neurocognitive failure in patients treated with hippocampal avoidance whole brain, plus memantine versus just whole brain radiation alone. So that's why I think that's the premise for potentially using hippocampal avoidance, whole brain radiation, whether it's PCI or just high dose 30 gray in 10 fractions. However, the premier study, which is actually from the European study that actually tests this question, whether hippocampal avoidance will also benefit patients receiving PCI. Of course, lower dose, 25 gray in 10 fractions. So interestingly enough, for this trial, is that when they actually compared that the decline from baseline to 3 months was lower in the hippocampal PCI arm compared to the PCI arm alone. Actually, it was worse. So it's not better, right? So it's a weird study in a sense that how could actually hippocampal avoidance PCI be worse in terms of the decline from baseline compared to the PCI arm. So, and then here, however, here is actually another study. This is actually another study, but they don't have an acronym for this. It's a phase 3 randomized trial, PCI versus with and without hippocampal avoidance. And they actually also showed no difference between the arms. And they actually showed that the hippocampal avoidance PCI was actually worse. So sorry. Previous study, the premier was showing the positive. Sorry. Here in this study is where actually they showed that the hippocampal avoidance PCI was actually worse in terms of outcome. In terms of neurocognitive failure, was actually worse in patients who were treated with hippocampal avoidance PCI. And then actually the primary endpoint was the Hopkins verbal learning score and failure on the Hopkins verbal learning test. And they found there was actually no differences in patients treated with hippocampal avoidance PCI versus a patient who treated with just PCI alone. So there's controversies. One study, the premier study, showing it was actually positive, showing that there was a benefit of PCI, hippocampal avoidance. Whereas this particular study showed actually there's no difference in hippocampal avoidance and potentially might even be worse for neurocognitive failure. So I think this is still a question that's actually still controversial in that the CC003, which is actually currently, it close to accrual last year, and it will be read out maybe perhaps in a year or so in time. And this is of course the RTOG NRG's trial, and hopefully might resolve the controversy in terms of whether hippocampal avoidance PCI will benefit patients. So whether you use it or not, I think some are still using hippocampal avoidance PCI, but just recognize there's some controversies related to use in the PCI setting. Okay, so I'm going to go on to the next case. I think we are good on time. Yep, we are. So case number 4 is a 70-year-old woman who is a heavy smoker who presents with extensive stage small cell lung cancer involving the right upper lobe, mediastinum, as well as bone. And the patient also have negative brain MRI. All right, so what would you recommend next? Is best supportive care, chemoradiation, platinum etoposide, just chemotherapy alone, or chemotherapy plus atezolizumab? Again, this is a patient with extensive stage small cell. Okay, so we'll just use standard chemotherapy, or actually D is more people voted for adding immunotherapy, and that's the correct answer. The current standard of care, unless there's some patients, and of course, not all patients will qualify for getting immunotherapy based on if they have some underlying autoimmune diseases, and they would not qualify, and chemotherapy will be the right answer. So yeah, you don't have all the information to make that decision. So I think maybe perhaps both answers will be correct, depending on the case. So in a patient who would qualify for immunotherapy, adding immunotherapy to chemotherapy would be the standard. And of course, there was really no advances in small cell, right? It's a very depressing disease, unfortunately, until just more recently, where just in the last few years, in 2019 and 2020, two immunotherapy drugs, atezolizumab and durvalumab, were approved. One based on the Empower 133 study, and the second on the Caspian study, approved for adding immunotherapy to standard chemotherapy, etoposide-based chemotherapy. So here's of course the atezolizumab trial, the Empower study, where they randomized patients to first induction, Tecentriq, sorry, I should use generic name here, with chemo versus placebo versus maintenance immunotherapy. The primary endpoint is overall survival. And of course, it showed that the progression-free survival time was improved. With these atezolizumab, still pretty depressing curves, actually, if you look at it. But then they did show a significant improvement with the incorporation of atezolizumab. And of course, there's an overall survival improvement with the incorporation of atezolizumab compared to the placebo. And of course, the Caspian study was using durvalumab instead of atezolizumab with durvalumab. Of course, they also had a 3-arm study. They also asked the question whether tremelimumab, which is a CTLA-4 antibody with durvalumab, whether that's going to benefit. Of course, that arm, it was not a benefit. There was no difference with that arm. However, they did show that in the durvalumab arm, that there was improvement in outcome compared to just the chemotherapy alone. And here's the paper that was published several years ago now, showing in the Caspian study, showing that incorporating durvalumab with etoposide-based chemotherapy improves outcome, both in PFS as well as overall survival compared to chemotherapy alone. Again, depressing curves, but still there is a benefit. So we can build on this, right, in the future. So in this particular patient underwent 4 cycles of chemo with atezolizumab, and there was a dramatic reduction in the size of the nodal metastases, as well as some sclerosis and healing of the bone metastases. In all areas is PET negative after treatment. There's also a resolution of the FDG avidity in the axillary as well as subpectoral lymph nodes. All right, so patient had a good response after chemoimmunotherapy. So what would you recommend next? Continue maintenance atezolizumab, consolidate radiation to all sites in 30 gray and 10 fractions, consolidate just to the thorax, 30 gray and 10 fractions, or 45 gray and 15 fractions. Wow, pretty spread out. All right. So, I think it wouldn't be wrong. I think, of course, probably based on the trial, we'll go over some of the studies in terms of there is, of course, a role for consolidated radiotherapy based on the European Slotman trial, right? And of course, I think B will be the right answer for that trial. Some sites, some places will use 45 gray and 15 fractions because there were still local control issues with 30 gray and 10 fractions if you actually talk to Ben Slotman. But in terms of whether it's wrong, it wouldn't be wrong to potentially consider maintenance atezolizumab and just actually treat on failure as well in terms of salvage radiotherapy. So next question is actually, so what is the role for PCI in extensive small cell lung cancer? The question, of course, one is there's no role for PCI in extensive small cell? PCI, this is a question, what PCI should be only used in non-metastatic small cell? PCI should be used for all extensive small cell, or PCI may be safely avoided in patients without brain metastasis on MRI. Hey, good. All right. You guys know the answer. Good job. All right. All right, so for this particular patient, we actually consolidated to the chest to 45 and 15 fractions. It's a common regimen. I know there's a trial, actually, Liz Gore's trial at RTOG that showed that you going to 15 fractions seems like there's not a benefit. But I think a lot of times, actually, because there was an increase in toxicity that's seen in patients who are treated in 15 fractions, we still use a 15 fraction regimen. We believe that actually it exerts a better local control if you use precise and good quality radiotherapy, in this case IMRT, in this particular patient. So we still treated this patient in 45 and 15 fractions to areas of previously involved disease in the thorax. And so patient developed grade 2 esophagitis with consolidated radiotherapy, otherwise tolerated therapy well. PCI was discussed. It was decided that PCI would not be offered given the lack of good evidence. Patient continued on tislelizumab after thoracic radiotherapy. So the question is actually, of course, what is the evidence for the use of consolidated radiotherapy in extensive-stage small cell, especially in the era of immunotherapy, and how about PCI? I don't think we have a very good answer, but because actually the CREST trial, which was the Ben Slotman study that adds evidence to the role for consolidated radiotherapy, really was done, of course, pre-immunotherapy era, right, in the patients who with extensive small cell. So, of course, this study, as you guys know, is a randomized trial to thoracic radiotherapy, 30 gray in 10 fractions, with PCI versus just PCI alone without consolidated radiotherapy. And of course, the primary endpoint at 1 year was not met. It was really actually only showed that the difference in outcome was only at 2 years in overall survival. So really kind of half yes, half no in terms of the benefit for thoracic radiotherapy. And so I think there's still we still need a study now, of course, to try to catch up to the modern era of incorporating immunotherapy. And so that's why this is actually a trial that's ongoing currently at the NRG level called L-USES-07. Quinn Nguyen at MD Anderson is the PI along with John Haymack. And so this is in patients who receive standard chemotherapy with atezolizumab, they're randomized to X-ray, radiation to the chest, along with 5 other sites potentially, up to 5 sites, and the dose can be 30 to 45 gray with atezolizumab versus just continuation of atezolizumab maintenance. So hopefully this trial is ongoing. It's actually a little bit slow accruing. We're trying to actually find ways to increase accrual for this trial with a few amendments that's actually has been approved. So hopefully it will be answer the question whether consolidated radiotherapy to not only the chest, but potentially even other sites of oligometastatic disease will potentially benefit patients in the era of immunotherapy. So what is the role for PCI in extensive-stage small cell? I think you guys all know the answer because you got the answer correct. Of course, this is Ben Slotman's old study, of course, the European study that showed there was a benefit of PCI in patients with extensive-stage small cell, which demonstrated that patients not only have less symptomatic brain metastases in patients who receive PCI, but also there was actually significant improvement in overall survival in patients treated with PCI in patients with extensive small cell. However, of course, criticisms, again, we talked about this, is that brain imaging was not even required, and patients were only excluded if they have symptomatic brain metastases. So this question in the era of MRI, whether PCI would be necessary, is actually, of course, answered by this phase 3 randomized trial in Japan. But however, of course, this trial closed early because of actually, due to futility, showing a benefit of PCI. Of course, the primary endpoint for this trial in the Takahashi's trial was showing that there would be a benefit of PCI in patients with extensive small cell. But after interim analysis of 163 patients, there was no way that it can show benefit of PCI. So that's the reason why they shut down for futility. And interestingly enough, actually, if you look at the median overall survival for patients who receive PCI, it was actually lower than the patient without PCI. However, PCI did reduce the future brain metastases rate, but however, there was no difference in progression-free survival. But more importantly, it's actually overall survival. See, look at this here, is that the overall survival is actually, the red curve is actually the PCI curve. So it's lower than the observation. Also, it's a trend, but it's a pretty strong trend of 0.094. Certainly not beneficial, right? And there's potential reasons why and things like that, but that's why we need the Maverick trial, right, to really show this. So I think for limited stage small cell, it's probably a lot easier to accrue because that question is still unanswered, really, by something like equivalent to Takahashi. I think many people are voting on their feet that because of Takahashi's data, is that a lot of our, clinicians are just not offering PCI for patients with extensive small cell now. So I think for you guys answered the answer correctly that probably MR surveillance is probably adequate for a lot of our patients with extensive small cell. So with that, we actually are done. Thank you. Any questions about small cell from your own cases, I guess, if you have any, you guys have any? Or anything else with Dr. Lee's question as well, yeah.
Sorry, Dr. Lee, thank you for your talk. I have a question, is that what's your dose constraints for normal organ at risk for the BID radiotherapy? Because I couldn't find references. So is it the same as the QD or
a little bit? No, a little bit different, of course, because BID, it's usually mostly the cord dose. You have to respect cord dose. So the lung dose, everything, it's really not too much different. But what is the biggest difference is actually in the spinal cord. So spinal cord, you don't want it because 45 gray is what we use for Q-day, right? Or even up to 50 gray dose constraint. But then for the core, it's really, if you actually look at this trial, it's 36 gray, but then really 41 gray is the maximum, D max. So we wouldn't go above 41 gray for the spinal cord. Typically, if you look at the protocol for small cell protocols, you can actually, if you have access to something, they actually have the dose constraint tables in the back.
So what about the lung V20 or V10?
Yeah, we actually we don't change on that. We still use the same mean lung dose of 20 gray, and the V20 of 35%. So that has not changed. Okay. Any other questions? Boy, you guys are hardcore. You guys are still here. So it's 5:13. We actually have about 15 more minutes before closing time. So please mingle, talk to us. So we have, while the other session is going on.